Hello people. In this question they have asked you the characteristics help differentiating bronchial asthma from COPD. What are the characteristics which help you differentiate bronchial asthma from COPD? They have asked this for 3 marks only. So let's quickly get to it. Bronchial asthma versus COPD. So you'd have to draw a table like this and then you have to write the differences. Okay. So bronchial asthma. First of all, look at this. Bronchial asthma is there here. In a normal person, in the bronchi, right, this is bronchi, they are showing here the airway, how much space is there, see. But in an asthmatic guy, what happens, the airway, the bronchi is full of mucus, okay, and it is inflamed. It's inflamed and it's full of mucus. So what happened then, there's narrowing of the bronchi, okay, bronchi or bronchioles. So this is a disease of the airway, asthma, allergic condition because of some allergic reaction, some hyper sensitivity. This has happened. Okay, so it is episodic. It will go away when after some time, when you're possibly away from the allergen or you just give it time. No, but what happens in COPD? It is chronic obstructive pulmonary disease. What is it? Chronic obstructive pulmonary disease. So this is a chronic condition. There's no relief in between kind of a thing. That's what they're saying. So here, it is not episodic. That's what they're saying. Here, actually, there are two types. Okay, there is chronic bronchitis and there is emphysema. Two things are there. So under COPD, there are two different things. Both of these are obstructive. Okay, asthma and COPD both are obstruction of the airway only. So the air is trapped inside; it can't come out. Now in chronic bronchitis, what is happening? The bronchus is there, right? The it is thickened. The bronchi are thickened. What is the bronchi are thickened? Okay, in chronic bronchitis, what is happening? It is thickened. The bronchi are thickened. But in emphysema, which is the second type that you should know, in emphysema, because of possibly smoking or long chronic exposure to pollutants, etc., what is happening? The air sacs, this is the normal air sac, right? Now, in this normal air sac, there will be some septa. All these septa are broken now and this air sacs are full of air, hyperinflated air sacs. This is a permanent condition, right? The COPD is an irreversible type of condition. But in asthma, it is reversible. It is episodic. I'm trying to say the same thing again and again, right? Okay. So basically you understood that in asthma, it is clear what it is. But in COPD, there are two varieties. Okay, that is what you have to understand. And you have to write both in the differences. Okay, now let's start off with other differences, table structure. Before that, what I told you, asthma, allergen you will blame. Chronic obstructive pulmonary disease because of some smoking, pollution, some alpha-1 antitrypsin deficiency, something. There is chronic obstruction, but none of these are infections, remember. But there is an obstructive condition, bronchiectasis, which is actually infective. So this is infective. The others is the other two. This asthma versus COPD. None of them are infective. Okay. Now, bronchial asthma. It is allergic, chronic inflammation of the airway, hyper responsiveness. Right, hyper responsiveness, possibly to an allergen. It will have what? There will be episodes of wheezing. Wheezing is the word that they are looking for. Wheezing. Okay, and this will particularly happen in the night and in the early morning. So there is a variation that you see, episodic kind of condition, seasonal, etc., etc. Now COPD, again I told you there are two types. So chronic bronchitis is what is happening. A lot of cough is there and sputum. Sputum is there. Okay, in chronic bronchitis, they are saying there is cough and sputum. Why this guy is going on coughing? Bronchitis is actually inflammation of bronchi only, right? Okay, then it is inflammation of bronchi. But this is not an allergic condition, remember. Okay. Emphysema, we told you, the air sacs are permanently damaged, because of which they are containing lot of air. Okay, especially the terminal bronchioles. Okay. The walls of these bronchioles are destroyed. Okay, this is the basic definition that much you have got. Now let's get into the other things. Asthma, they're saying, is reversible. COPD, they're saying, is irreversible. This age of onset can be childhood, adolescence for asthma. COPD is long after some life, because they have to get chronic exposure to these things. So you can say after 40 years kind of a thing. But asthma can be there for above 40 also. Above 40, even asthma can be there. Okay. Onset, they are saying, in childhood it can start. It's asthma. Okay. Then mast cells IgE sensitized, that allergic, right? So where will you write this point? You will write it for asthma. Where is the alveoli damaged? Alveoli damaged in emphysema. Okay. Then where do you have dry cough? Asthma. Chronic productive cough, where will you have? Chronic productive cough in chronic bronchitis actually. Then we told you that this is another thing. If there is exertion, the COPD patient will be perfectly fine. As soon as he has some exertion, he might have cough or breathlessness. But when it comes to asthma, it is more of the trigger that happens, okay, which will cause this breathlessness and dry cough. Okay. Next, wheezing word you write for asthma. Asthma word, wheezing word, where will you write? Write it mostly for asthma. Okay. Now coming to the main difference. Let's go to the next slide. So bronchial asthma versus COPD. Guys, you have to say that even exercise can trigger asthma. Okay. Exercise can trigger asthma. In chest X-ray of asthma person, when he doesn't have an attack, his X-ray will be fine when he doesn't have an attack. But in COPD, always when you take the X-ray, chest X-ray, you will see hyperinflation of air sacs. If it is emphysema, hyperinflation of what? The air sacs. There'll be a flattened diaphragm because the lungs will be like this. How will the lungs be? Hyperinflated, pushing the diaphragm down and flattening the diaphragm. Poor diaphragm will become flat because the lungs are hyperinflated and pushing it down. COPD. Okay. Now, most important point is coming here, spirometry. Guys, spirometry is the most important point. This is how you will differentiate asthma from COPD. Remember, this is what they're asking for 3 marks. How will you differentiate asthma from COPD? Now, asthma, you have to do a pulmonary function test. You check their pulmonary function test, and then what you do, you give them a bronchodilator. Post the bronchodilator, like any salbutamol or something you give, ask them to inhale, and then after that, when you immediately do a pulmonary function test, you will see that the FEV1, that is the forced expiratory volume in first second, 1 second of expiration, how much volume of air is coming out when he forcibly expires. See, inhale, expire forcibly. The first second, how much volume of air comes out? There is a significant improvement in FEV1 post bronchodilator. Okay, so look at this image here. This is a normal person. This is normal person's pulmonary function test. This is asthmatic guy's pulmonary function test, but we'll look at this one. So asthmatic guy, FEV1 is 1.8 liters. Normally for me, let us say it is around 3.4, that is the reference rate, but for asthmatic guy, it's coming 1.8 liters only in the first second of forced expiration. Then what we'll do, we'll give him some bronchodilator, salbutamol, levosalbutamol, all that, and then what you will check post, you will ask him to repeat this test, and then you will see that there is an improvement is there, and now he is giving out 2.5 liters of air in the first second of the forced expiration. FEV1 has increased. This will say that it is asthma. So that is the whole difference. So when you check, okay, the FEV1, if it increases by 12%, FEV1 increases by 12%, greater than or equal to 12%, and 200 ml. 200 ml also has to come out air. Okay, following what? Giving a bronchodilator or a trial of glucocorticoids, any one of this if you give, then you can say it is asthma. Or you can see that if you don't have this bronchodilator or steroid, then what you do, you make that, you take the pulmonary function test of this guy, and then you make him run. Or they are saying here exercise. Okay, make him exercise for 6 minutes, and then what will happen to FEV1? Obviously, it can't increase. You have not given bronchodilator or steroid. Okay, so basically the FEV1 will reduce further now. Just be careful. Okay, don't give him some attack. So if the FEV1 decreases by greater than or less than 15%, then it is asthma, you can see. Okay, exercise induced asthma maybe. Okay guys, there's one more point here that you need to focus on. Are you looking? Are you here? Okay, so we are looking at one more point, PEF, okay, peak expiratory flow they are talking about. Diurnal variation of this peak expiratory flow also you can check. Okay, that's what they are telling here. So diurnal variation of this peak expiratory flow you have to maintain when diarrhea and check 20% something. Okay, leave that there. Let's continue with our differences. So we are done with spirometry differences. Now coming to steroid response. Guys, focus here. Very important for you to write in the exam. Steroid response is excellent in asthma. You have to give inhaled corticosteroids like budesonide, fluticasone, all this you can give. Okay, budesonide, fluticasone. Okay, and then systemic means prednisolone orally they are talking about. Okay, that's what you have to remember. Steroids for asthma. Now coming to COPD, you will say LABA and LAMA. Okay, so LABA is long-acting beta agonist, and LAMA is long-acting muscarinic antagonist. Okay, it is an antagonist here. I'll use the red here for the antagonist action. So, so look at this. So these are bronchodilators. So what are they telling? Bronchodilators you should give chronic condition, right? They're giving long-acting bronchodilators like LABA or LAMA, and oxygen therapy also. You give oxygen, but not so much oxygen also that you have to make it some perfect saturation. No, that I think you need not maintain perfect saturation. Read about that more. But LABA and LAMA you write. LABA, long-acting beta agonist, which will do bronchodilation. Example, salmeterol, 4-meterol. LAMA, you will say LAMA, that is long-acting muscarinic antagonist. So this is nothing but an anticholinergic. Remember, anticholinergic. So it will prevent bronchoconstriction. An example for this you will write. Example for this you will write. Yeah, here. Tiotropium. Okay, this will prevent bronchoconstriction. Example is tiotropium, ipratropium, bromide, glycopyrrolate. These three are the examples. Okay. So almost we have covered a lot of information for differences between bronchial asthma and COPD. Thank you.